So I'd like to bring you back about now almost 20 years to a Bay Area classic, one of my favorite films from the early 1990s, before Austin Powers, when Mike Myers was a slightly less famous but equally bad Scottish actor. And he was playing both a father and a son in a movie called So I Married an Axe Murderer. Can I see a show of hands of people who've seen that film? Okay, not too many people have seen that film. It's a great rental. I would urge you to rent it. But the father is named Stuart. The son is named Charlie. Tony is a friend of Charlie's. And Stuart is Mike Myers in a kilt. And he's really kind of dressed ridiculously. And he says to his son and his son's friend, well, and forgive my very poor Scottish accent, I'm a tiny fraction of me is from the British Isles, very tiny fraction. But he says, well, it's a well-known fact, Sonny Jim. There's a secret society of the 5 wealthiest people in the world who are known as the Pentaveret, who run everything in the world, including the newspapers, and meet triannually at a secret country mansion in Colorado known as the Meadows. And Tony, his friend, says, so who's in the Pentaveret? And Stuart says, the Queen, the Vatican, the Gettys, the Rothschilds, and Colonel Sanders before he went belly up. And then he says, my favorite line of the movie, he says, ooh, I hated the Colonel with his wee bitty eyes and that smug look on his face. Ooh, you're gonna buy my chicken, ooh. Dad and the son, who's also, he's an Americanized American of Scottish descent, says, Dad, how can you hate the Colonel? And he says, because he puts in an addictive chemical in the chicken that makes you crave it fortnightly. And so what do you think is the addictive chemical in the Colonel's recipe? So I went online, where we can now find a lot of things that we thought were secret and are not secret anymore. So what is the Colonel's recipe? And I found this t-shirt, which I placed on my then 12-year-old son, who's now several inches taller than I. And you see the writing on that shirt, which says, assault with a deadly weapon. And you see, this is the Colonel's famous recipe: a little bit of flour, salt, thyme, basil, oregano, more salt, tablespoon of celery salt, a teaspoon of garlic salt, 3 tablespoons of monosodium glutamate. This is basically the Colonel's secret recipe that makes us crave it fortnightly. So just a little bit about the conspiracy theory, and to talk with you a little bit about what is the regulatory status of salt in the United States. Now, most of you probably know that intentional ingredients in food, just like pharmaceuticals, are subject to FDA pre-market approval, unless they fall into this very protected category, which is known as GRAS, or generally regarded as safe, or were approved prior to 1958. Now, I know none of you were born before 1958, but for those of you who might know some people who were born before 1958, salt was listed as part of the U.S. Code of Federal Regulations as the archetype substance that was considered generally regarded as safe. And it says in the U.S. Register, it is impractical to list all substances that are generally regarded as safe, or GRAS, for their intended use. However, by way of illustration, the commissioner, meaning the FDA commissioner at that time, regards such common food ingredients as salt, pepper, vinegar, baking powder, and monosodium glutamate as safe for their intended use. So think about that, generally regarded as safe. And think about the Colonel and those wee beady eyes. And then think back to 1970. I know most of you were in grade school with me at the time. President Nixon, who now I think would be considered probably the most liberal of all ever living 20th century Republicans, convened the Federation of American Societies for Experimental Biology's Scientific Committee on GRAS Substances. Basically, he commissioned a group of people to regulate the food industry. Can you imagine a Republican president doing that? Well, he did, and the motivation was cyclamate. Some of you probably remember, many of you probably remember the soft drink Tab, which was the first popular diet cola, and it used to have an artificial sweetener in it known as cyclamate, and there were considerable concerns about its safety, and so the president actually commissioned this group to get together to discuss GRAS substances. And this, in 1970 now, the conclusion was that the evidence on sodium chloride is insufficient to determine, and look about these words, think about these words for a moment. They sound like lawyers wrote them, not doctors. To determine that the I'm sorry, I'm sure there is an attorney or two in the crowd. I'm very fond of attorneys too. That the adverse effects reported are not deleterious to the health of a significant proportion of the public when it is used at levels that are now current and in the matter now practiced. Now, can anybody guesstimate for me what it means to say a significant proportion of the public at levels that are now current and in the matter now practiced? Now, how many of you have had Kentucky Fried Chicken or Popeye's chicken or Safeway chicken or virtually anything processed in a store or a restaurant in the past couple of years? I imagine most of you, including
Roasted chicken?
any of them. Injected with salt, virtually everything. It turns out that in addition to the 10 or so pounds that our entire population has gained since 1970, and the increase in salt content that comes with increased caloric intake, the dietary sodium intake of the current United States population is considerably higher than it was in 1970 as current, at levels that were current in 1970 and in matters now, that is 1970s practiced. There's a tremendous amount of salt that's been injected, placed into processed foods since then, and one could make strong arguments against this statement based on the evidence even that was available then. Now, there was growing concern among the research community during the early 1980s. So what did the 1980s, when there was a real Republican president who was really anti-regulatory, you all remember that. I mean, we were all around in 1980. Even you were here then. They would not classify salt as a food additive, but they favored individual choice. That sounds like Reagan, right? Choice. Or maybe not. Labeling rather than regulation, and noted difficulty in setting and enforcing limitations. So of course, if it's, I mean, I wish I could say that about my kids, because it's difficult to enforce limitations, I just won't make them. And deferred a decision on GRAS status. And it turned out that, so 1970s, there was this ruling that there was insufficient evidence to take away the GRAS status. In 1982, the FDA addressed the issue because of growing concern. And then it took 25 more years for the FDA to even open their eyes to think about salt. And they still haven't withdrawn GRAS status, but a few of us who are trying to make a difference are pushing them in that direction. So just to think about a few useful conversions when you're at the market. And I talk to my patients all the time and they say, oh, I read labels. And the truth is, if you're reading labels, you're probably buying the wrong food if you're trying to reduce your salt. So don't go to anything in a box or a bag if you're interested in reducing your salt intake. Go to the fresh fruits, the fresh vegetables. Can anyone tell me what is the greatest source of dietary sodium intake in the United States, the one single food source that's the greatest source of salt? Chips, potato chips, French fries. Any other ideas?
Soy sauce.
Bread.
Someone said bread. You're absolutely 100% correct. High five for the lovely lady in the burgundy purple shirt. That's right. Do you know what the second highest source of salt is in the diet?
Soup.
Sugar Coke
So, so soft drinks, it's interesting that you would say that because salt and sugar do go together, and it's not coincidental that the same companies that market soft drinks also market salty drinks, because they make each other more, they crave each other. But no, that's actually not true. There isn't a huge amount of salt in cola drinks. It happens to be probably, if I'm not mistaken, the largest source of calories in the United States, but not of salt. So bread is number one. Does anyone know what's number two? I won't belabor this. Nora, you must know. I mean, you're so well educated. Who has or had young children? Breakfast cereals. Yeah, really. You don't think of them as salty, but this the second greatest source of dietary salt. So when you're looking at labels, not too many people make their own breakfast cereals, but cream of wheat or oatmeal, it's a lot less expensive and a lot less salty. 1,500 milligrams of sodium, about 6.5 grams of salt, about 3.5 grams of sodium chloride. So this is 3.8 grams of sodium chloride or salt. 1,500 milligrams of sodium is actually what the Institute of Medicine recommends for dietary intake for adults over the age of 55, or anyone with high blood pressure, or anyone with diabetes, or anyone who's African American, or anyone with kidney disease. Which, if you bring all of those groups together, you've got about 2/3 of the US adult population. So salt sensitivity is not rare. Everyone knows stories. You know, everyone has an Uncle Joe who smoked like a chimney and lived to be 100. And everyone has a buddy who eats salt like there's no tomorrow, hot dogs and chips and everything else, and has no problem. But for the average population, we're talking about moving the average intake either to the left or the right, depending on our diets and secular trends that the food industry has. We're way above 3.8 grams. Does anybody know what the average intake of an American diet is? Nora, you must know this. Pardon me? For salt. Can you guess?
About 4,000 milligrams.
4,000 milligrams. So for sodium, 4,000 milligrams. So you're saying somewhere in the order of 9 to 10 grams? That's your guess? Yeah, that's about right.
That's daily. It doesn't say anywhere they're daily.
No, that's daily. This is daily. So that's about 9 to 10 grams of salt, where recommended intake is about 4 grams or less. And this is not dealing with anyone who really should be on a salt-restricted diet. I mean, this is for, you know, average intake for people who don't have heart failure or kidney disease. We already discussed this. What are the sources of dietary sodium? This has been repeated multiple times. Somewhere between 75 and 80% of dietary sodium comes from processed foods. It is not harmless. The magnitude of the problem with hypertension, everyone remembers the advertisements from the 1980s about the silent killer. Okay, that was a pretty effective advertisement at the time, but it's waned. And there are a lot of factors and processes that have distracted us from salt. And we'll talk a little bit more about that. But over half of strokes and about half of all heart and blood vessel events, coronary heart disease events, can be attributed to hypertension. So we're all thinking about cholesterol. We're all thinking about smoking. I'm not suggesting that smoking is healthy or it's healthy to have high cholesterol. But people have been distracted and not paying any attention to salt because they've gotten a lot of mixed messages over the past couple of decades. The estimated risk of developing hypertension in developed countries like ours, where we're assaulted since childhood, is up over 90%. And if you look at other countries throughout the world where the dietary salt intake is not so high, there isn't this natural increase in blood pressure with age. I've seen patients who say, yeah, my doctor told me 100 plus my age is an okay blood pressure. So I see a 70-year-old person who says 100 plus my age, 170, that's acceptable. Well, there's a lot of evidence suggesting that that's a not ideal blood pressure for a 70-year-old person by any means. If you look at the US population, this is some data from the National Health and Nutrition Examination Survey, a general survey that captured a lot of people in the US, a representative sample of the US. Only about 40% of adults have normal blood pressure as defined by blood pressures less than 120/80. And when we look at about a quarter with hypertension and about a third with so-called pre-hypertension or mild hypertension, we're talking about a national public health problem, a major national public health problem. Now, there was a very important study. There are many, many studies. I won't go over all of them. One very important dietary modification that can give you a general sense of how powerful the effect of sodium reduction can be is something called the DASH sodium study. And if you're interested in eating a healthy diet that can help reduce your risk of hypertension and vascular disease, you can Google DASH. It's Dietary Approaches to Stop Hypertension. A DASH diet is a healthful diet with whole grains, fruits, vegetables, low-fat dairy products, modest amounts of chicken and fish, very small amounts of red meat, nuts and other things, other sources of protein. And a study using two different diets, a typical American diet and a more healthful DASH diet, and 3 different levels of salt intake were compared. And I'm going to remind you what these sodium intakes were. So we're looking at 3,200, 2,400, and 1,500. And I showed you 1,500 is considered the target value. So we had kind of target, low American, and medium American. And there were no people in this study who had a typical American diet. And these figures don't really show, they're hard to read from the back, but what they show you is if whether or not you're on a healthy diet or an American diet, if you reduce your salt intake, you can see on average about a 5 millimeter of mercury reduction in your blood pressure, your systolic blood pressure, which if we use a medication and we get 5 millimeters of mercury, we're like, way to go. That's pretty good in our clinic. When we see someone with a 140 and we get them down to 130 or 132, we're very happy with one medication. So a diet that reduces the salt intake is as potent at lowering blood pressure as many, if not most, of the medications that we use. And those changes are even more pronounced in certain groups: blacks with hypertension, other patients with hypertension, older patients in particular. So now, we recently had a paper published where we took these data, and again, this is just really for demonstrative purposes. We took data from a simulation model where we incorporated anticipated changes in blood pressure that might be expected if we lowered the American diet, not from 10 grams to 4 grams, but just by, say, 10 grams to 9 grams. Or 10 grams to 7 grams. And what this slide shows for non-black men, non-black women, black men and black women, mortality, stroke, heart attacks, we're seeing 20% anticipated reductions just by those small incremental changes in blood pressure. And these are hard to read, but this gives you an idea of the public health impact of dietary salt intake. We would save about 28,000 deaths in the United States per year if we could reduce the dietary salt intake by 1 gram. And so just to give you some context, this is on par with health reductions that would be seen by major losses in weight, much greater than statin therapy. Any of you take statins to lower cholesterol? Much greater reductions than are afforded to patients who use statins to try to prevent heart attacks, and about half as many lives saved as all medications used for hypertension combined. So we're talking about, and these are not massive reductions in dietary salt intake. What we're talking about for the individual person, we don't appreciate how important a 3 or 4 or 5 millimeter of mercury change in the blood pressure, getting the blood pressure from 145 to 140. To, you know, for one person, you know, we don't have a crystal ball. We don't have a document that tells us that we're going to live until we're 87 years old, and then we're going to have a stroke, and then we're going to die. We don't have any of that information, so you never know for an individual patient where he or she would have been under different circumstances, but you can model the population effects of these interventions, and they're massive. And it's not because the effect is so huge, but it affects every single person in the United States. So if we could shift, just like if we could get the whole country to be a little bit more fit, and we just got us to lose a little bit of weight on average, the whole country would save thousands and thousands of lives. And the same could be said for salt. So I think if you think as a public health official or a potential public health official, smoking, weight loss, and dietary salt intake are the 3 most important preventable risks to our longevity. And we're seeing after many, many years of extensions in life expectancy, we're seeing that begin to tail off. Despite better medications, a lot more health knowledge, a lot more information, hopefully more access to health care if health reform is not repealed. A lot of good interventions, cholesterol-lowering drugs, blood pressure medicines, a whole bunch of things that are effective. We're seeing that extension in life expectancy waning. And that's, I think, because of these 3 ongoing threats to the public health. So in summary, the majority of the dietary sodium in the US comes from processed foods. Dietary sodium has increased substantially from 1982, and even more substantially from 1970 when it was practiced currently. Lowering sodium intake would save tens of thousands of lives annually. I would argue, and I invite you to, if you're friends with your congressperson or your state representative, California is a, in front of the pace kind of state. Talk to your state senator. Bloomberg has done this in New York. He's instituted recommendations. They've all been non-mandatory recommendations. But a lot of the restaurants in New York have made concerted efforts to reduce salt intake. And frankly, New York is outpacing California in innovation with respect to dietary salt. Salt is no longer grass. It is not generally regarded as safe. We are assaulted every day. And that's why I ask you, is this a national conspiracy? Certainly, I think salt should be regulated as a food additive. And there's a section within the Federal Food, Drug, and Cosmetic Act where it should be regulated. And I just do not see the rationale for longer shelf life or better mouthfeel as satisfactory to assault us. And what's worse is we're in Palo Alto. This is a beautiful, affluent, well-educated community on average. There are plenty of people here who are very needy, but on average we're very educated, we're very affluent. Think about what it's like for a single mom trying to hold down a couple of jobs with young kids who just can't find a Whole Foods or can't find a grocery in her neighborhood. and how difficult it is. I don't think that the idea that you can leave it up to people's choice. A lot of people don't have the resources or the availability of fresh, healthy foods to make those kind of choices. So the dietary sodium intake recommendations for you to take home from the IOM are 1,500 milligrams of sodium for virtually everyone in this room. There are a few people, I know Nora's 26, but for most of us, I'm not 55, but for most of us 55 and over, and any of us with hypertension, 1,500 milligrams per day. So why has there been no action on this in 25 years or more? There are some other factors. Dietary potassium, calcium, fiber, and other factors in the diet have also been implicated as potential mediators of blood pressure control. There are a lot of confounding factors, people with kidney disease, diabetes, and other things that can render the associations that we find difficult to disentangle. But we have been assaulted by the fast and snack food industry. You should know that Frito-Lay, and I have nothing against Frito-Lay, well, I do, but Frito-Lay supported a calcium campaign to release the pressure on sodium. They funded researchers. There's a place in New York called the Salt Institute that has done research mostly on demonstrating that calcium is associated with blood pressure, that has done nothing but to confuse us and distract us from the true fact that salt is a hazard to our health. I'd encourage you, for the conspiracy theorists among you, go to Centers for Science in the Public Interest, CSPI.net.org, and look up the Salt Institute and look at the people who are, and there are some very distinguished academicians who have conducted so-called research laundered, funded by the Salt Institute with funds from Frito-Lay and other snack food companies. I think also the FDA and public attention directed elsewhere, has been directed elsewhere, and I don't want to make jokes or make light of things like breast implants, but the FDA spent decades trying to demonstrate that breast implants were harmful, when in fact they were not. And I mean, I don't have breast implants, but there were a lot of things distracting the FDA. And if there's one thing that affects the public health, smoking, obesity, and salt, this is what our federal agencies should be concentrating on, not breast implants. So, they've softened up the kernel. They don't call it Kentucky anymore. They call it KFC. Yeah. There are a lot of marketing ploys now, but there's a national conspiracy. Hopefully I've educated you a little bit. Those of us who practice internal medicine, cardiology, nephrology, I'm a nephrologist, a kidney specialist, we deal with high blood pressure every single day in our clinic. And every single patient that I look at in front of me, much as I try to use evidence, I'm sure you've heard the term evidence-based medicine. We try to use evidence on which to make our decisions and guide our practice. Something called SPRINT, the Systolic Blood Pressure Intervention Trial, Goals, Rationale, and Design. I can tell you that I have no idea where the blood pressure target should be. I can tell you if the blood pressure's here, if it's 180, it needs to be lower. But does it need to be here? Or does it need to be here? And just because people who are walking around who do not have high blood pressure are doing better when they're down here than here, doesn't mean that treating high blood pressure from here to here is better than treating high blood pressure from here to here. And we don't know the answer to that. So we are trying to determine whether a treatment strategy aimed at reducing systolic blood pressure to a lower goal, that is 120, compared to a more modest goal of 140, for which there is evidence of benefit. You go from 180 to 140, there is definitely evidence of benefit. We're trying to determine if this will reduce the occurrence of cardiovascular events. And we're also very interested, particularly in elderly persons, to see whether more intensive control of blood pressure would improve health, improve cognition, prevent deterioration of memory and mental capacity, as well as preserve kidney function, which is another issue and another topic we can talk about another time because kidney disease is really important. Now, why is the National Institutes of Health conducting SPRINT, and why are we so enthused about this? Well, I think I've hinted at you that high blood pressure is one of the most common conditions among middle-aged and older adults and is the leading risk factor for stroke, heart attack, chronic kidney disease, and several other conditions. Previous trials have demonstrated the effectiveness of treating systolic blood pressure to 140 millimeters of mercury. Observational studies, meaning not trials, not experiments, not tests, but just observing people, have suggested that there may be benefits to lowering blood pressure, but we don't really know that because we've never tested whether lowering the blood pressure with medications to those levels will save lives. So there are about 1 billion people in the world with hypertension now. Over 1/3 of a billion in developed countries, about 72 million in the US. Remember, I told you about 25% of the US population, and that's not considering the 33% or so with pre-hypertension, with mild hypertension. And if you look, and this is a busy slide, but you can see that this is particularly common in Black or African American men or women. You can see that the prevalence rates, or the fraction of the population affected by hypertension, and these are looking at time trends in red, blue, and white. You can see over time there's been a general trend, particularly in Blacks, toward higher prevalence of hypertension. It's about 40% in Blacks and about 30% in non-Blacks. Not surprising, kidney disease and stroke is a much bigger problem for Blacks, elderly people with diabetes. You can see that as we age, and again, this is not a natural phenomenon. This is not something that just naturally happens. This is part of the assault of developed countries in the 21st century. It's expected that people over the age of 75 will be hypertensive. I don't think that it has to be that way, but I'm not sure that our diet, environment, stress, other things have not programmed us in such a way that you can see this very striking increase in the prevalence of hypertension among older folks. It actually turns out that lowering blood pressure in younger folks is even more important. It saves even more lives than lowering blood pressure in older folks, even though the risks are much lower in younger folks because they have so much more cumulative lifetime ahead of them. It matters even more for younger people. So when you see your kids and grandkids eating that crap, you gotta tell them to stop. So there have been some other studies that have demonstrated that lowering blood pressure to 140 does make a difference. And we've been able to lower the incidence of stroke in particular. Does anybody know what blood pressure President Roosevelt was running as he was negotiating with Churchill in the 1940s, like for the future of the world? His blood pressure was about 260 over 170. It's a wonder his head didn't explode. That guy must have had a very powerful brain, because that kind of blood pressure would stun a lot of people, much like a concussion would. So, there have been a lot of improvements just by recognition that hypertension is a risk and treating some of these people with exceptionally high blood pressure values. We've reduced the rates of myocardial infarction or heart attack by about 1/4 and heart failure by about 1/2. So heart failure is the most common reason for persons over the age of 65 to be hospitalized in the United States. And hypertension is the leading contributing cause for hypertension. Now, at a JCC, I can't help but say that Chinese food on Sunday nights is also a common cause of hypertension and heart failure. So the benefits do relate to the extent of blood pressure lowering, but also in the context of the SALT discussion we had earlier, multiple medications are usually needed. So you can see here that the risks in these trials can be reduced by a lot, even if the reduction in blood pressure seems quite small. So what we see here are about 20-25% reductions with 5, 6, 7, 8 millimeter of mercury average reductions in systolic blood pressure. So anything that we do, whether it's better sleep hygiene, a little bit of exercise, a little bit of weight loss, a 1 gram reduction in your dietary salt intake, adherence to your medications, actually taking them every day instead of skipping them when you feel like it, they all make a major difference. This slide just points out that it's very hard to control hypertension. One medication is usually not enough. And if you look, these are 8 or 9 trials with the abbreviations on the left and the achieved blood pressure target in the treatment group. And you can see even to get to a 130 to 140 goal, generally the patients needed 2 to 3 blood pressure medicines to get there. So I wouldn't be too discouraged. The medications need to be taken in conjunction with other lifestyle modifications, but one is usually not enough to get you where you need to be. Now, there have been studies, as I said, observational studies that show that the risks, and lower is better here, this is mortality from ischemic heart disease or heart attacks or heart failure. And you can see that no matter the age by decade, that the mortality rates tend to be much higher in the general population with blood pressures of 180 compared to 120. So these are the data from which we make the assumption that 120 should be our target blood pressure. The truth is these are people who are living in the population and not necessarily people who are on treatment for hypertension. Now, who knows anything about the Women's Health Initiative? And who knows anything about estrogen replacement therapy? Were any of you participants in the Women's Health Initiative? There's a Stanford site. Congratulations. Thank you for participating. Wonderful. Good for you. Good for you. Have you enjoyed being a research subject?
Oh, yes, I do, every chance I get. I'm serious.
Excellent. No, there's so much to learn, and there's nothing that one can do that's more generous than sharing one's own health and information to the betterment of others. We'll talk more about that. But the Women's Health Initiative, part of the Women's Health Initiative discovered something very important. Have any of you heard of something called the Nurses' Health Study or the Physicians' Health Study? These were epidemiological studies that were conducted out of Boston with my old buddies at Harvard, whom I used to work with. And they showed in the 1990s, early 1990s, that women who took estrogen replacement therapy lived longer, had fewer heart attacks, fewer strokes. And what happened to any of you who happened to be going to physicians around that time, any of you in your, say, 60s now? What were your doctors recommending estrogen replacement therapy during menopause? They sure were. All around the country. Was it on the cover of Time magazine? Yeah, it sure was. And the entire country, the entire generation of women, postmenopausal women, were given estrogen replacement therapy because the observational studies showed that women who took estrogens had lower rates of heart disease. They lowered their cholesterol. It all made a lot of sense. Well, the Women's Health Initiative, Stanford was one of the leading sites. You know, I'm getting at this Stanford-Harvard battle. But Stanford was one of the leading sites, and the Women's Health Initiative, as part of an array of studies, did a randomized clinical trial where they actually compared treatment with estrogens compared to treatment with placebo. And does anybody know what that showed? Do you know what that showed?
Well, it showed that the reverse was true.
Exactly. There were a higher risk of some cardiovascular diseases, stroke, a higher risk of cancer that was not discovered in the epidemiological studies. And we call that confounding by indication, meaning that there are other factors that are confusing the connection between the exposure, in this case estrogens, and the outcome, in this case cardiovascular disease. So women who were health conscious, who exercised, who took good care of themselves, they were the ones taking estrogens. It wasn't an experiment though, and it wasn't proof. So they were part of a healthier lifestyle, and maybe the healthier lifestyle led to lower cardiovascular disease. They exercised more, they ate better, they had lower body weights. That's confounding, confusing. The randomized clinical trial helped to educate us. We know that lower blood pressure is associated with lower rates of cardiovascular disease. What we don't know is whether the treatment of hypertension to lower targets is better or worse. A study was conducted in people with type 2 diabetes to answer that question, and it wasn't a huge study, but it suggested that it wasn't better, and it might be a little worse in some instances. In some instances a little better, in some instances a little worse, overall about the same.
The lower blood pressure?
That's right. No difference. Now there's an immense association between blood pressure and stroke. I think we've discussed that. So this trial which we're doing, we're going to try to answer this question, just like the Women's Health Initiative did with estrogens, about the treatment of hypertension in people who have hypertension by randomizing them to a group treated to a target of 140 compared to a target of 120. So we won't have confounding by those other factors. We'll actually know the answer. We will also know whether lowering blood pressure improves or impairs cognitive function, which after life or death is probably the thing that most older people are most concerned about and most anxious to maintain. There will be 2 arms, many centers. We're one of the leading centers here at Stanford. 9,250 adults with systolic blood pressure at least 130. And we're looking at all cardiovascular events and also looking at kidney function and cognitive function and health-related quality of life and other issues. We're going to be recruiting over 3,000 seniors, persons over the age of 75 around the country. Somewhere on the order of about 200 people at Stanford. Over the next 18 months, we've been recruiting for about 3 to 4 months. Over the next 20 months or so, we'll be recruiting persons, and they'll be followed with us for about 5 years. And we see them on a regular basis and work with their doctors to help control their blood pressure. So I mentioned this one because I want to dispel the myth that we know all the answers about hypertension. We don't. There's a lot of controversy out there. Part of the controversy is salt-related. We discussed that earlier. Part of the controversy is that we really don't know where our target blood pressure should be. I also want to take the opportunity to invite you, if you wish, to learn more about this study and potentially participate with us, because and forgive me, what's your first name? Karen, as Karen has shared with us, there are a lot of benefits that can accrue to people who participate in trials and other studies. It's not necessarily health benefits, but it's knowledge benefits. It's benefits in knowing that you're contributing to the health of the next generation of people with this very common health condition. So if you've had a stroke or you have diabetes, you're not eligible for participation, but if you have high blood pressure and you do not have either stroke or diabetes, chances are you will be eligible. And if you're over the age of 75, we'll be supercharged, super excited to bring you in, because we're particularly thrilled to bring in seniors. And we've got a 3,250 patient goal. Yes, ma'am.
Are placebos used in this?
Not at all. No. So it's interesting in that it's not a kind of typical experiment. Nothing really is experimental. It's just more comparing strategies. A strategy of a 140 target versus a strategy of a 120 target. The medications that we use are all the common medications that are used for hypertension. But we might use them a little bit differently. So if someone has a blood pressure of 150 and he or she gets assigned to the 140 group, we'll probably go light on one or two medications and bring the blood pressure from 150 to 140. On the other hand, if someone's assigned to the 120 group, we'll probably need a little bit higher doses of medications and maybe 2 or 3 medicines instead of 1 or 2.
How long,
Pardon me?
how long are you on the regimen?
For the entire study period, and thereafter if you wish.
That's just to determine the dosage of medicine,
No.
the types of medicine?
No, it's to determine whether you feel better and live longer, depending on which of the two strategies you're assigned. And we don't know the answer.
Systolic number that you reduce it to.
Right. So,
Are people feeling better at 150 versus 140?
you know, sometimes people feel no different at any blood pressure. That's why people often call it the silent killer,
So it's whether or not they live longer than
or have fewer heart attacks, strokes, and other things. Hopefully everybody's going to live a long time. But just to summarize about Sprint and high blood pressure in general, high blood pressure is a leading cause of death and disability in the United States, no doubt about it. Current treatment approaches are effective but challenging and leave residual risk. More intensive control might prevent strokes, cardiovascular disease, dementia, and progression of chronic kidney disease, but we don't know. And it could also promote more symptoms. It could make people feel more listless. It could make people feel less well. We just don't know. And so I actually have a whole bunch of flyers if you want to learn more. There's contact information for our study coordinator. It's a pretty intensive project. We have people coming to visit every 3 months, every month for the first couple of months while we get you on track, every 3 months for 5 years. It's not too far from here over on Arastradero Road, beautiful building called the Center for Patient and Population Research. But if any of you have friends or family members or colleagues who have hypertension and are interested in doing something wonderful for your community, participating in a study like this is very important. I would make a couple of other quick points before I'll open up for questions. You should know that this study is one, again, where we're not using any experimental treatments. It's sponsored by the National Institutes of Health. There's an independent data safety and monitoring board of distinguished scientists who are going to be looking at the data every couple of months to make sure that one group isn't doing much better or worse than the other, in which case the study gets stopped. Anyone who participates, if, for instance, Karen wanted to participate, she could participate, and if she didn't feel well, she could withdraw any time, or if she were in the 120 group but she didn't feel well when her blood pressure went that low. You know, the idea is to have a target, but it's not to torture you. So if you are assigned to the 120 group and you feel lousy at 120, we do everything we can do to get you feeling better, and if the lowest you can get to is 126, that's where you end up. You know, safety and well-being trumps the targets of the study, but part of the whole idea is to separate the groups so we can answer the question, just like we've answered the estrogen question with the Women's Health Initiative. Yes, Nora?
If you're on a blood pressure medication and your blood pressure is being maintained at 120 or below, would you have to change that medication to participate, or would they allow you to stay on that medication?
Well, we have a menu of medications that are either exactly the same or very similar to the medications that you're on, and we provide those medications free of charge for the duration of the study. So for instance, if someone has hypertension and their blood pressures are now 130/80 on, let's say, Ramipril, Altase, and chlorthalidone, Hygrotin. Those are two commonly used blood pressure medicines. That person would be eligible for participation in the study, and then depending on which group he or she were assigned, we would either keep those medications or make minor adjustments to them, and then have someone either on 140 or 120. So the only requirement is that you have to have high blood pressure. Don't want to be in a study if you don't have hypertension, if you don't have hypertension. And if you have diabetes or a stroke, then those people are excluded. Yes, Karen?
Wouldn't you have to go off your medication to find out how high your blood pressure is?
No, if you have hypertension and you need blood pressure medicines to be below 140, then you would qualify. So the question is, why does Karen's doctor tell her, even though she feels perfectly well, and she shared with us some of her personal health information, which we're not allowed to share unless someone shares it herself. So she shared with us that she has high blood pressure and high cholesterol. Those are very common conditions, but feels very well, and I'm delighted about that. So I don't want to be critical of your physician. Your physician is kind of giving you the party line. And the party line is that you look at the observational data and you see that 120 is better than 140. But the truth is, if you're hypertensive, if you have hypertension and you're over 140, we don't know whether lowering it to 120 or even below 120 is a benefit or detriment. So I think she's drinking the Kool-Aid. So what are the potential downsides of lowering the blood pressure? And there are, having low blood pressure that's natural without prompting by medication is very different than pushing the blood pressure down with medication. So medications can have side effects. They can have important side effects. Many of the blood pressure medicines nowadays are much better tolerated than the medications of the 70s and 80s. But many of them do have side effects. Cognitive impairment is an important side effect. Fuzziness that people complain about when they're on some blood pressure medicines. Several of the blood pressure medicines can cause sexual dysfunction, and not just erectile dysfunction in men, but sexual dysfunction in women. And that's another thing that we're assessing very carefully, but we're assessing in the study, because if pushing the blood pressure to 120 because someone says that it's better, and that causes you to feel foggy and goofy during the day and be unable to enjoy sexual relations, then is it worth it? I mean, we don't know. How many events? So I would think that for many of us, if there were a substantial improvement in our longevity, we might put up with a little bit of fuzziness or maybe a little bit of sexual dysfunction, but other people would make different choices. The truth is, we don't know the answer, and so your doctor is telling you what kind of a lot of doctors say, and I'm not suggesting that I have all the answers. But nephrologists, those of us who care for people with kidney disease and hypertension, this is kind of in our wheelhouse. This is what we do every day. And I can tell you, we've very carefully reviewed the literature. And every institution that's participated in the study, we had to submit this study protocol to Stanford, and they had to review it for safety and appropriateness. And there are doctors, attorneys, lay people on those committees that make judgments as to whether these studies are ethical. And I can tell you, the evidence to lower the blood pressure below 120 is just not there. There might be 3 or 4 patients that your doctor cared for who whose blood pressure was lowered and they did very well, but there's really no evidence that lowering blood pressure to that level is of benefit. And that's why we're doing this study, to try to determine whether there is or not. So the question is about diastolic blood pressure, and why haven't I focused on it? Now, I mentioned to you that Roosevelt had a diastolic blood pressure of 170. That's super high. And not too many people nowadays go undetected with blood pressures that high. There's enough health screening, and even people without insurance are often somehow screened somewhere, somehow. There are still people who have blood pressures that high, but not as often as there used to be.
How about below 60?
Yeah, so we're going to talk about this. So the problem with diastolic blood pressure is that the observational data are very confusing, and the actual physiology is very confusing. So when the diastolic blood pressure is very high, like 120 or above, like Roosevelt had, that's very dangerous and very high risk for heart failure and stroke. But likewise, and particularly among the elderly, when the diastolic blood pressure drops, it's a reflection of vascular stiffness. So the blood vessels, and I don't want to get too, first of all, I'm not an engineer or a physiologist, but the blood vessels are supposed to be pliable and soft. And so when the heart pumps, the blood vessel takes that blood and expand and contract, and expand and contract. And the blood vessels should be nice and pliable and movable and soft. Blood vessels are supposed to be soft. Bone is supposed to be hard, right? So what happens in a number of settings, kidney disease, diabetes in particular, but even just regular aging, is that the blood vessels tend to get stiffer, the bones get softer, the blood vessels get stiffer. That process is accelerated in people with kidney disease, hypertension, and diabetes. But even for healthy elderly people, the diastolic blood pressure begins to drop. So it's very hard to determine whether a diastolic blood pressure of 70 or 75 is actually an improvement or a detriment to patients, because as people age and their blood vessels become more stiff, the diastolic blood pressure drops. And there have been a number of studies that show that the distance between the systolic and diastolic blood pressure, called the pulse pressure, is an even more powerful predictor of cardiovascular events than either the diastolic blood pressure or the systolic blood pressure. So what used to be called isolated systolic hypertension of the elderly, ISHE, a person with 180 over 50, people didn't really know what to do with that for many years. Now we know that that's a sign of poor vascular health. And so that's another good reason for us to really try to understand what are the actual benefits or detriments of treating the systolic blood pressure. Because if we lower the systolic blood pressure, which we believe may lower the risk of stroke and heart failure, based on the observational data and some of the clinical trials that have brought us from 180 to 140 and seen significant benefit. If lowering the systolic blood pressure also lowers the diastolic blood pressure, do you know when the arteries supplying the heart are filled with blood? Well, I'm giving you a leading question, but the arteries that supply the heart with blood fill up during diastole. They fill up, so the heart pumps, sends blood out through the aorta to the rest of the body, and then as it relaxes, it flows blood back to the heart itself. The aorta sends blood back through those coronary arteries, those three main coronary arteries, back to the heart. And if the blood pressure during diastole is too low, there could be impaired flow through those coronary arteries to the heart. And what if, for instance, there's plaque, or a stent, or a blockage of some type? and there's insufficient flow. So we really don't know what to do with diastolic blood pressure. We know that when the diastolic blood pressure is very low or very high, there's an increased risk, and somewhere in the middle is best. But we don't really know a lot after that. And certainly trying to push the diastolic blood pressure below 60, 50, 40, we have no evidence to support that strategy, and there's a lot of potential risk associated with that. Good question. Jerry had an excellent question. So I'll answer this question specifically about the study and then just more generally about hypertension management in your lives. So yes, definitely is the answer. Whenever people have other health conditions, we have to consider other medications. There can be what are known as drug-drug interactions. Certain medications will interact with certain other blood pressure medicines. So diuretics are very commonly used for hypertension treatment, and one class of diuretics has an absolutely opposite effect on calcium and bone metabolism as another class of diuretics. So whether a person has osteoporosis or heart failure or other diseases, then definitely. So for SPRINT, we're very comprehensive with respect to evaluating the health history of the patient. I'm one of 4 or 5 doctors involved, but I'm the principal investigator. I'm the lead physician with the study here at Stanford and one of a handful of nephrologists who are leading the study. That we're looking very carefully at the other health conditions of patients and using those conditions and the flexibility of the study to guide therapy. So for instance, there isn't a fixed medication that you have to go on. As I said, it's a target, either 120 or 140. And if you have an enlarged prostate and difficulty urinating, we might choose a blood pressure medicine that helps men ease urination. If someone has heart failure, we might use a medication that's also beneficial for heart failure and hypertension. If someone has osteoporosis, we might use a medication that can help reduce the risk of fractures as well as lowering blood pressure. So definitely we do take consideration. And outside of the study, in your own experience and that of your family members and friends, one of the most important things to do is to think about all of the medications that you're on. It's a bit of a cocktail, or a witch's brew is probably a more apt description. And one of the things that the Medicare has recommended for all physicians at all ambulatory visits is to do what's known as medication adjudication. So some people do that more religiously than others, and some people do that more formally than others. I know at Stanford, when my patients come in, usually the medical assistant reviews their medication list, and like it or not, I sit at the computer and I'm often editing and adding and subtracting medications as I learn what other medications the patients have been on. So we keep a living document of the medications that you're on, and I'd encourage you all to do that. It will help facilitate your care at a number of your doctors, and we certainly do that with the study. So let me kind of try to paraphrase that. So I would say, again, specifically related to the study and then more generally related to practice, what blood pressures do we use to assess the control of hypertension? And you mentioned that you have an Omron device at home. Omron, and I have no connection with the company. It's a company that makes home blood pressure monitors. I actually have one at home. It's a very good device. You can purchase it at Costco for about $45. And I think if you have hypertension, it's well worth buying one. And they're quite good. And when I've tried to calibrate them against the manual sphygmomanometers in my office, they almost always work very well. So for the study, we're bound by the visit blood pressures. But the visit blood pressures are formally done after 5 minutes of resting, sitting comfortably without any noise in a very quiet room in a lovely place. and they're averaged three measures that are averaged, and our decisions are based on the average of those three measures. In practice, I think it's very informative for you to bring in your home blood pressures. And even in the study, I'm utilizing information that people bring with me at home. Sometimes, even if they're sitting and relaxing for a few minutes, if they had a ride on the freeway and they got a little bit out of sorts, or they thought that they were late. Now doctors were always late, so, we understand if people are a little bit late. So we do take into account when we're making subtle changes. If your blood pressures on the Omron are 130/70 consistently, and you're in the 120 group, and we measure you and you're 160/90, we're probably not going to hit you over the head with a big dose of new medication to try to lower your blood pressure further. So I think it's useful to measure your blood pressures at home. The Omron device is a really good one. And bring that information into your doctor's office. If Nora will allow, I'll be happy to take another couple of questions. Absolutely. And anyone who wants, you can pass these out. You're, of course, not obligated to participate yourself, but I would be thrilled if you would be what we call Sprint ambassadors. So you're certainly welcome to contact Jennifer or me. She's our study coordinator. If you want to participate, if you're over 55. There are a few of you younger than 55 in the group, I think. But if you're over 55, you can participate, and you can certainly learn more. And don't throw this out. Share it with your friends and let us know, because this is a very exciting study, and we want Stanford to lead the way. So how do you pick a good hypertension specialist? So generally speaking, since hypertension is so common, a specialist in internal medicine or nephrology or cardiology is going to have a lot of experience managing hypertension. There are certain people who, there's a society called the American Society of Hypertension. There's a special certification examination for hypertension specialists. I've actually never taken that exam. I would pass it, I think. But I've never taken it just because it always comes around at a time that I'm busy and it's a big exam, but whatever. I think, generally speaking, if a person who's a specialist in internal medicine is a good choice for, the witch's brew. And if the blood pressure is difficult to control, that's often when we get called. So for routine management of hypertension, usually it's your primary care physician. And we've been getting a lot of referrals to the study from internists at Stanford and elsewhere who have heard about the study and are not convinced that blood pressures of 110 are the absolute, mecca. So they're trying to learn with us. If your blood pressure is very difficult to control, a nephrologist would be a good bet. We have about half a dozen spectacular faculty, most of whom I've recruited, who are great. Well, so we're looking at events over time. So how many people over time develop things like heart failure requiring hospitalization, or heart attacks or strokes? Hopefully very few under my nose, but some at some point will develop some complication over 5 years. And then a number of questionnaires, which are fun and informative, I think, for you. So health-related quality of life questionnaires that ask you about your health and well-being. Cognitive testing, since that's an important component of the study. So a number of tests of memory, what's called executive function, complex tasks, drawing things, remembering things, words, and so forth. Sexual function, sleep function, other things. So we're looking at all of those things. It's not burdensome. The initial visit takes about an hour and a half, and subsequent visits take about 15 minutes. But you'll get sick of us after a couple of years. So the question is, green tea and might lower blood pressure, and are there other foods or drinks that lower blood pressure? And then, I'm sorry, what's your name?
Yvonne.
Yvonne chimed in that
Watermelon
watermelon and cucumbers.
I've tried it and it works because they're cooling foods.
Okay, interesting. What I can tell you that green tea has a lot more caffeine than people think. Caffeine is an appetite suppressant. Eating less can lower your body weight, and that can lower your blood pressure. But of any specific blood pressure lowering effect of green tea, I'm not aware. I've not heard. Now, chocolate just makes you happy, so your blood pressure lowers when you're happy. I've not heard about watermelon and cucumbers.
Yes, it does. I've tried it.
But watermelon, well, see, so you have an N of 1 trial. We need an N of 9,250. But one of the important things about watermelon and cucumber are that they have no salt, and green tea has no salt. So I can tell you, relative to Cheetos and Fritos and Doritos, watermelon and cucumber are relative blood pressure lowering foods. I don't know of any actual formal studies which have shown that those foods lower blood pressure. But again, I think when you're thinking about diet, the key to dietary modification of blood pressure is the DASH diet and a low sodium diet. Now, sniffing peppermint tea makes people want to pee. That's unquestionable. That's what we used to do when I was a medical student and someone had just had surgery. We used to put peppermint oil in the room so that they would pee. But if you're interested in dietary approaches to lower your blood pressure, a diet rich in fruits and vegetables, which are rich in potassium and calcium. Potassium and calcium do lower blood pressure a little bit. They're not nearly as potent as salt, but they do affect blood pressure. So learn more about the DASH diet. And anyone in our trial, by the way, we encourage people to undertake any and all lifestyle modifications, including weight loss and exercise and meditation and acupuncture and dietary modification and watermelon and cucumbers that they want to do as an adjunct or even as primary therapy to control blood pressure. The question was, well, what do you think about salt substitutes like potassium chloride? And it tastes a little weird, but it does taste a little salty. My comments would be, if you're going to use them, make sure you tell your doctor. They can interact, this gets back to Jerry's question, they can interact with some of your medications. If you're on medications like the ACE inhibitors or ARBs, the prils or the sartans, ramipril, lisinopril, captopril, enalapril, ramipril, all of those. If you're on any of those medications, or if you take other medications, say for arthritis, and you take salt substitutes, they can be dangerous. The other point I would make about it is to remember that there are salt receptors on your tongue. They're called ENaC, or extracellular sodium receptors, epithelial sodium channel receptors. And they're very labile. You can up and down regulate them. So if you decide to go on a lower salt diet, the first few days, maybe a week or so, you'll notice it. And what will happen after 3 or 4 weeks is you will begin tasting a bouquet of new flavors that you never knew existed because they were all drowned out by the salt in the food. We're again spoiled because we live in Palo Alto. Most of us have access to beautiful things and beautiful food and fresh things. I encourage any of you when you're traveling to think very carefully. If you go down to the southeast and you go to a restaurant, even just as an experiment, try something small. Go into a restaurant in Atlanta and try some food. And you will have no idea how salty the food is, and the people who live there don't notice because their ENaC receptors, their epithelial sodium channel receptors, have been upregulated in the tongue. They can be downregulated very quickly. And what do these restaurants do to, again, to get back to the conspiracy theory, what does these restaurants do to cover over crappy, sour, old, icky, miserable, lousy, cheap food? They-
Deep fry.
Well, they fry it and they salt it. And they sugar it a little bit too.
With butter.
Yeah, all those things. And we don't notice it, and we get accommodated to it. So I would say, yeah, if you really like salt, you can try a salt substitute. Just tell your doctor and be sure it isn't interfering, because it is potassium chloride. And if you're on a medication that impairs your kidney's capacity to excrete potassium, or if you have diabetes, which can often result in high potassium in the blood, you want to be very cautious about taking salt substitutes. And I would say, you really don't need it. Just, go off salt for a little while. Like they say, I've never been a smoker, so I'm very sympathetic to people who've smoked. My sister smoked for 25 years, and it kills me every time I see her. But, after a couple of weeks, there's still a psychological dependence, but the physical dependence wanes. After a couple of weeks, you've downregulated your ENaC receptors, and you won't be able to eat the food that you used to eat. You should have seen me. You would have laughed. I had a conniption fit in our hospital cafeteria the other day. I was so hungry. And I was in clinic from like 1 to 5, and I went to the cafeteria to get something to eat. And I hadn't eaten lunch. And I wanted to eat something, and I have a 45-minute drive home. So I went and I got some soup, and it was so salty. And I told them, this is a hospital cafeteria, and I was ranting and raving. People were giving me a hard time because the soup in the hospital cafeteria, relatives of people who are sick, some of them are older, they can't drive out and go anywhere. They were feeding this stuff. So, anywhere you go, even in a hospital cafeteria, you'll find it. So is there any disadvantage to taking your blood pressure medicines at night? Generally, no. Depending on the medications that you're on, depending on your other health conditions, there may be some advantages to taking certain blood pressure medicines at night if the effects are most potent soon after the medications are given. So there are a number of differences to different blood pressure medicines, and many of them now are formulated in ways that you only need to take them once a day. But even those tend to have a more potent effect in the early hours after taking them than in the later hours. So if they happen to be medications that dilate the blood vessels, that open up the blood vessels, say, in the periphery, in the lungs, in the legs, and the arms, and you take them early in the morning and you get up abruptly and the blood just pools in your legs, you could get lightheaded. So for some medications, depending on you and the medications and your other health conditions, it may be advantageous to take it at night. The other thing about taking medications at night is that you can leave them near your toothbrush and on your night table or something, and you remember to take them. So I really try always, whenever I can. We have a lot of choices now. We didn't, when I was starting practice in the late 80s, early 90s. We have so many choices now. We can almost always treat someone with a once a day or at most a twice a day medication. So it's very hard for anyone to take any medication more than 2 times a day.
And for this program, what is the age limit?
55, and the sky is the limit. One of my 95-year-old patients is going to sign up next week. She's outstanding. Oof. She's going to blow them all away on the cognitive tests.
Thank you. This was terrific. Thank you.
Thank you for coming.